Dr. Suresh is going to speak about surgical barriers to transplantation.
Still good morning. All the talks before had a lot of data and everything. Mine is going to be a very simple surgical talk about what the barriers for a renal transplantation from a surgeon's standpoint. It's a very basic talk. So this is how we do transplant, right? Transplant that's our abdomen, picture of our abdomen. You can see the God-given 2 kidneys which have failed and the new kidney which is given by man. We have three connections, one to the artery, one to the vein, one to give blood, one to take away the blood, and the ureter anastomose to the bladder down there. Another picture there, something very similar. See this is how we do it. And believe it or not, I'm going to show it in the picture next. The kidney resides where? Not in your belly, outside your belly. What in the medical term is called retroperitoneal. You put it most of the times outside the belly. So to start off with a little bit of history, actually the first transplant was done by actually a plastic surgeon along with Dr. in Brigham, Dr. Murray. He did with monozygotic twins. So when we start talking about transplants from a surgeon's standpoint, it's a technical operation. But is that all we need to do a transplant? So we have there's a lot of trials that have gone on, experimentation, whatever we've done. How did we come? Who are the stakeholders? First and foremost, somebody's kidney failed, like Dr. Sege was talking. You in South Africa, your kidneys fail. The next step is you don't make it. Right? The first step you need is renal replacement therapy. So we need nephrology, where we can support them till you can give them a transplant. And second is who gets which kidney? How are you matching? You got to match them. You got to understand the HLA antigens, blood group matching, what needs to be done. And the next step is, yes, you're going to transplant, but not all the time you have the patient next to you who's going to take the kidney and go in. But you have to find how you're going to preserve this. What is the best way to take the kidney from the donor to the recipient, whether it's living, deceased. Fourth is the topic, surgical barriers or technique, how we do them, and how it was done before. And after this, again, we need how to overcome the immunological barrier, where the patient has to keep the kidney for himself. How do we do this? These 5 steps are the stakeholders doing transplant. We're not going to talk about all this, too much. We're just going to talk about point 4, surgical barriers, how we can do this. So first and foremost is a stable hemodynamics. If you don't have a strong heart, you can't go into general anesthesia. If the heart isn't up pumping, the kidney doesn't receive blood. Normally, 25% of your cardiac output goes to your kidneys for filtration purposes. So if your heart is not strong enough, your kidney transplant ain't going to work. So it's very important to have a good cardiac restratification to see if this patient is going to be a candidate and this transplant is going to be viable. Next, what are we going to talk about today? Place to implant. I need a place to put this kidney where I can give it an inflow that is oxygenated or blood from the heart that goes in, and a place for the blood to exit the kidney and go back into the systemic circulation. Inflow, outflow. And the last is you need access to the genitourinary tract. Means the kidney produces urine, so we got to get this out. So it could be bladder, it could be the native ureter, it could be something else. We'll talk as we go along. So 3 important technical aspects that we need to be able to think about before starting the journey. So next is a brief video. Okay, this is how we do a transplant. Most of the time we make incision the right side or the left side, which is paramedian next to the muscle, the 6-pack we see in the movies. You go through the skin, and that's your Scarpa's fascia, what we see. So once we go through that, what we see, the white layer is called the external lobular aponeurosis, which covers all the muscle. We expose that. That's the muscle. Sometimes we can spread the muscle, or we go through the muscle spreading incision. We spread the muscle. That we see is the preperitoneal fat, and those are the inferior epigastric vessels which are there, which are usually divided, or the cord, whichever you can think. And in men it's the cord, in women it's the round ligament. We divide that, and that's the peritoneum. We'll push it, and you have access. So you're outside the belly. So that's back is the psoas muscle, also called the fillet, people who eat steak. That's your vessels. This is the external iliac vessels. Right above is the aorta there. And what you see, the internal iliac vessel, external iliac vessel. The common iliac is becoming two parts, internal and external. This is the kidney, which is sent to us on a pump or in ice. Like you say, has three connections. The red is the artery, the blue is the vein, and the yellow is the ureter. So we bring the kidney in, place it, and we clamp the vessel so that there's no blood flow in the part we're sewing, because you cannot sew while you're doing it. Okay? We move the artery away. You clamp it so there's no flow. You make a venotomy. So suctioned out. You sew it. It's called the end-to-side anastomosis. You suture it. You leave the clamp in place because you don't want warm blood entering. This is still it's out of ice. Once the kidney came out of ice and we started our warm ischemia time. That marks the end of the cold ischemia time. Now we clamp the vessels. We see at two different spots to prevent blood flow again. And again, the same thing, end-to-side anastomosis. Here, what they use is an aortic punch, where we can punch a hole in the vessel because we want the flow to be good, or you can just do a slit. You do end-to-side anastomosis, and then once you're ready, this is the most important part, you have anesthesiologist in the room, and you release your clamps, marking the end of warm ischemia time. It's still, yeah. So the kidney is receiving blood. Now you will see urine coming out, especially if it's a living donor. Now you reposition a retractor, you find the bladder, the ureter is put under the cord. In men, for women, you spatulate it. That's what it's called. What they did with the scissor right now is called spatulating it. So you have a wider surface area. You make an incision. That's the muscle on top of the bladder. You remove it, and that's the urothelium. Once you open it, you see water coming out. Usually you would have filled it with water or a three-way Foley. This is what they're doing right now is called the Leach-Grigor technique of anastomosis, where you close it. But here, Dr. Coons created a new technique, what we call the single-use stitch technique, which we use, which has been very successful. And then you close the muzzle on top to create an anti-reflex mechanism. Because every time you pee, the bladder contracts, it kinks the ureter so that the urine doesn't go back into the ureter and causing pyelonephritis or UTIs, which is not as effective, but it's effective in some places. So that marks the end of your transplant. You push peritoneum back, you close up the fascia, leave the muscle. I tend to leave a drain. Dr. Roshan doesn't leave a drain. They're both full up top. And you close up, and that's your transplant in a nutshell, right? Key is access, and planning matters. So now, since we understand how transplant is done from a certain standpoint, we can go to the next step. What are the barriers to doing this, right? There are many. I just listed 4 for the purpose of the talk. 4 common things we see here at Downstate. Peripheral vascular disease, morbid obesity, bladder issues, somebody who's had problems with bladder, it could be any side, and retransplant, right? So these are the 4 things. So we'll go one at a time. So start off with peripheral vascular disease. What does that mean? We are using blood flow that goes to the lower extremities as our inflow to the transplant, inflow and outflow. So if that blood flow to the leg is already compromised, we can't be using that, right? Most of the people have high blood pressure and diabetes. The vessels, because of chronic disease, including end-stage renal disease, have these things deposited in them, which we call as atherosclerosis, that makes us putting those clamps, which you saw, very difficult. If I put a clamp in something that's become like a lead pipe, you crack the vessel. Not only you're not going to be able to put the kidney, you lose the blood flow to the leg. You compromised it. So that's why we end up getting CAT scans or various workup to see how these vessels are, what is the native state of these vessels where you're going to be putting this kidney. So when we see on CAT scans there's a lot of calcification or there's no flow sometimes, it can be a soft plaque which cannot be seen without a contrast, then we have to plan appropriately. So this is the main problem when there's a narrowed blood flow. And there are different types. We'll go through one at a time. So this is another close-up view how it looks. This is a bifurcation, most common. That's the aorta on top there, and that's the common iliac bifurcation. The most common point where this happens, and this affects our inflow, blood. So wherever you put the kidney, we put it on the external iliac artery. This common iliac becomes external, going to the leg, internal, supplying the pelvic organs. This area is the most common area where calcification occurs because of hemodynamics. And when this happens, you're losing the blood flow to the kidney. There's compromised flow to the kidney, or you put your clamp there. We recently had a patient, and that vessel will crack, causing dissection, and your kidney doesn't get good flow. So it's something to keep in your mind in the preoperative workup. Look at this CAT scan here, which we see all the time. There's no flow, there's no inflow there. There's no way you can put a kidney on the right side. Whereas the left side, yeah, you have some, can I move my mouse here? Yeah, I can. Oh, everybody can see. Okay, so you can see no flow here. There's a lot of collaterals that is sort of able to supply blood to the leg on a normal, this person, if he walks, he probably will have right lower extremity pain because this blood flow is not going to be, the blood is not flowing through a highway, it's going through a parkway. So eventually reaches the leg in a resting condition, but he strains that leg, he'll have rest pain. The left side is pretty okay, but though it's calcified, you can see all the calcifications. So, this is something we do here at Downstate. We are able to take these high-risk cases and we find a small sweet spot there and we're able to put these kidneys there. You have to plan them very well. Usually you have to have a clear planning, not an old CAT scan. See if there's a spot where you can put these clamps, or sometimes the clamp you put may not be adequate, like complete hemostatic, but you still can get the kidney in place. This is something that's going to be impossible, right? It's called monkey bug calcification. There's calcifications all over. It's almost impossible to do it, but we have done a couple of these cases, but involves a lot of risk. As you can see, the aorta is got, this is a mini aortic aneurysm here. You can see a small one, probably about 4 centimeters. And then as you go along, you see these calcifications that make it very, very difficult to put your clamps. So doing a kidney transplant in somebody like this, it's going to be very difficult. Another picture where it's completely calcified all over. So this probably precludes this person from getting a kidney transplant. So look at this here. This is a case I want to show when somebody has such bad peripheral vascular disease. You can see this is a stent here. It's inflow stent. It's an old CT. Usually you don't do this because it sort of impinges on the right side. What we do now in vascular surgery is called kissing stents. You put stents on both sides, but here there's only one stent. And again, there's another stent in the external iliac artery on the right side. But this is a case which probably we do it here at Downstate. So you can actually put a kidney on the left side here. See, there's a spot here. You can probably get it in. But to do that, we have to improve inflow here on the left iliac side. If you can do that, this is something, though it looks precarious, but this is something we can do. So that was about inflow, outflow, and doing transplant. Next step we go is morbid obesity. This is a topic of contention between me and Dr. Rashan. So this is description of what obesity is described, right? Somebody is below 25 is a movie star, 25 to 30 is overweight, 30 to 35 is obesity, 35 and above is morbid obesity. If you look at the Medicaid guidelines, anybody who's got obesity above 35 with sleep apnea, diabetes, or hypertension, even including arthritis now, gets qualified for a bariatric surgery. But what are the types of obesity? So when we look at BMI is just like a number, like we spoke in the talk earlier about KDPI. It really doesn't, it's a number. You cannot look at a number to make what's happening here. in the last picture here, this patient will be a perfect candidate for transplant. It doesn't matter. The problem happens in the first picture and the third picture. Even the the fifth one is all right. It's when you have centripetal obesity with the overhanging pannus. That's where it is. Is it not doable? Yes, it is doable. You have to have techniques to minimize the risk of complications in these patients. What are the complications? It's difficult surgery, bigger incision, wound complications. But do the grafts do well? Yes, the grafts do fine. But if you can get them better before you get them to the transplant, where we go through the intervention. What are the interventions? Many of these patients get obese not because of eating. 30 to 40% of these patients have mental health issues. They need to be evaluated by a social worker or a psychologist why they're overeating. Because the reason you get there is because of something else that's going on in your life that leads you to there. So you really need to be evaluated by a nutritionist and a social worker to figure out why this started. And then come up with formulate a plan how you can do this. Is it possible by lifestyle changes realistically, or does it need any other intervention? So this is just to get the patient better, but it should not preclude somebody from getting a transplant. Because if somebody is young, like we are going to be doing a transplant in our list, the person got a bariatric surgery, his diabetes is getting better, blood pressure gets better, sleep apnea gets better, weight loss is there, you do a transplant, you're like overhauling the patient. They get better from all aspects. Your post-transplant care will become much easier. But is it absolutely necessary? No. But the way you optimize the patient with respect to weight loss and sustained weight loss is what makes a difference. So bladder issues. We see all the time bladder cancer, neurogenic bladder, posterior urethral valve. There are many issues with respect to bladder. So you need access to the genitourinary tract because the urine has to go somewhere. So there are many ways of doing it, right? If somebody who doesn't have a bladder, you can do an ileal conduit, you can do mains before we go there, when we know somebody has a bladder issues, you work up. Voiding cystic erythrogram one with post-void residual is a urodynamic study to figure out, is this bladder going to work or not? But why do we need to do that? Because when somebody has a bladder issue, it's not excreting well. The main problem we see is recurrent UTIs, which can take a toll on the kidney and have graft loss. So the key is we have to have a clear plan established how we're going to get the urine out of the patient's body. A clear plan. So once you've done appropriate workup, then preoperative, if you have a plan, how are we going to do it? Ileal conduit, mains pouch, cock pouch, Indiana pouch, bladder augmentation. All these things can be done, and the results are excellent. The most common problem you see when you do these are electoral abnormalities, which are very easily correctable, supplementation and close follow-up. UTIs. UTIs are the main cause of problem when somebody has a bladder issue because of recurrent, they lose the graft, is mainly not because of rejection, not because of other things, it's UTIs. So that's something to consider. Retransplant, like we said, we have God given 2 external iliac arteries. You use them both up, you have to plan the next. So to simply give you a small picture, right? We have this picture here. Now, we put a kidney here. It's on the common iliac. Normally, we put it on the external iliac here. You put it on the external iliac here. So now, once we used up, we can go up to the common iliac. We can go up on this on a common iliac. But usually, somebody going through 4 transplants is rare, right? Because usually something else takes over and it doesn't happen. So the most important thing you have to figure that out is it going to be retroperitoneal? Are you going to do intraperitoneal transplant? And you probably have to do UU if you cannot have a ureter long enough to reach the bladder. So planning is important. We've done retransplants here. Number 3, we have done here number 3. We have not gone to number 4 yet. But that's something that you should plan. A good CAT scan, a good social work eval, because you need to know why this patient lost 2 kidneys. Are we doing the right thing? Is it worth taking the risk? If it's a medical reason and it's been done correctly and the patient satisfies all the criteria with appropriate imaging, planning, it's doable to do another transplant. Simple talk, right? Anybody, any questions? All right, no questions. Thank you.